This video is part 5 of Chapter 10, Abnormal Psychology for PSY 110S, the Psychological Sciences. In this final part of the chapter, we're going to talk about treatment approaches beyond the biomedical. And that means we need to talk about psychotherapy. I pulled this definition from the National Institutes of Mental Health so that we can have sort of a working understanding of what we mean by psychotherapy. Psychotherapy refers to a range of treatments, a lot of different tools that are designed to help people understand and change emotions, thoughts, and behaviors that are problematic for them. Most psychotherapy is done one-on-one with a licensed mental health professional, and it could be, there are many different types of these professionals. They're trained in a variety of ways. Most of them have, very similar tools in their toolkits. Cognitive approaches, behavioral approaches, approaches that focus on emotional regulation, and so on. In general, what psychotherapy is designed to do is to give people relief from symptoms that cause them distress, to help them improve their functioning, their adaptive functioning, and, just globally to help them feel better and experience greater happiness and joy in their lives. Psychotherapy can be used by itself, or it can be used in tandem with other kinds of treatments, including medications and other biomedical approaches. Even when you have medications that work, that effectively relieve some of the symptoms, psychotherapy can be helpful to address other kinds of issues. So, for example, if you have a person who lives with schizophrenia and their medication reduces their psychotic symptoms and improves some other aspects of their disorder, what it doesn't change is how the person feels about themselves, how they deal with their everyday issues of managing their disease, and how working in the direction of healing relationships with family members, and maintaining their stability in the context of having that particular diagnosis. So in that case, psychotherapy can be very helpful. Again, this comes from the NIMH. There are a variety of possible elements that can be delivered in psychotherapy. In some cases, you're dealing with cognition. So helping people to understand the way they're thinking, especially inaccurate, harmful forms of thinking, can interfere with their ability to function in an effective way. Teaching people how to question thoughts, how to change their thinking so that it will improve how they feel and how they act. And this is like a staple component in cognitive behavioral therapies. Some psychotherapy approaches emphasize methods of coping with stress and problem-solving strategies. Some approaches emphasize social and communication skills. Increasing in popularity in recent years has been adding in mindfulness and relaxation therapies, including meditation and breath work. Exposure therapies may be involved for anxiety disorders. So where in a supportive environment, people are learned stress tolerance approaches so that they can tolerate distress for longer and longer periods of time. And people are taught to track their emotions and understand in a more complete way how their emotions and actions have impacts on each other, how they are reciprocally interactive. There may also be a more classical version of psychotherapy where you're dealing with unpacking trauma and getting emotional support while you do so. Also, sometimes psychotherapy will involve creating plans to address dangerous thoughts, self-harm thoughts, thoughts of suicide, and putting into place plans for mitigating those sorts of thoughts. There are several broad categories of psychotherapies, and this is a little bit oversimplified, but it can be helpful to sort of categorize them a bit. There are so-called insight therapies, which emphasize helping the person develop a deep understanding of who they are, what they do, how they feel, and maybe why they feel that way. This originated with psychoanalytic or psychodynamic psychotherapies, but it's also true of humanistic or person-centered therapies. Other therapies could be described as so-called action therapies, and I think that word has been chosen because people doing cognitive therapy and behavioral therapies are very active. They have to do homework. So in cognitive therapies, you're often doing homework assignments designed to expose the problems in your thinking, and then you're doing homework to challenge those negative thoughts and replace them with more adaptive thoughts. In behavior therapies, you're being taught ways to manage emotional reactions to situations and to alter maladaptive behaviors, replacing them with adaptive ones. There are also more holistic approaches that are a blend. So some treatments for trauma, for example, involve some of the humanistic aspects, some psychoanalytic aspects, but also cognitive and behavioral aspects as well. We'll start with the psychoanalytic / psychodynamic therapies. Classical psychoanalysis was criticized early on for being really expensive and time-consuming, and for putting the therapist, the psychoanalyst, in a position of power over their patient. In early Freudian psychoanalysis, basically Freud and people he trained, they were to interpret what their patients were experiencing and then tell their patients what they were experiencing. It was very directive, and the person's own experience was always questioned in terms of its validity. So that model has shifted to be more open-minded and a little more interactive. But the assumption, of classical psychodynamic or psychoanalytic approaches is that a lot of the problems people have are associated with early childhood experiences that are anxiety-provoking. Classical Freudian psychoanalysis, the assumption was you had repressed memories, fixations, unresolved conflicts coming from childhood trauma. Now, the idea of repressed memories, really super controversial, and it's one of the reasons that psychoanalytic approaches had lost favor, was because you can't prove that any of those things happen. In tandem with research that showed limited returns on investment, the model really had to shift in a more positive direction. Modern approaches to psychodynamic theories still argue that the unconscious matters, particularly when people have experienced trauma, but they're going to move a little more in the direction of shorter-term, insight-based approaches. So the goal for psychoanalysts is to kind of help the person discover and get insight into some of the unconscious motivations and defenses that are shaping their behavior and causing them suffering. So the major task is to interpret sometimes the coded messages that are coming from a person's unconscious and help give the person insight into those. The critics of the psychoanalytic approach have been that, unconscious conflict, particularly repressed memories, are problematic and unlikely to be the root of most people's problems. That has resulted, as I mentioned before, in modern psychodynamic approaches being more short-term, more targeted, and more patient-focused. So instead of the classic Freudian approach of the therapist knows all and the patient knows nothing, in modern psychodynamic approaches, it's still insight-based, but they tend to be focused on specific problems that people have, and they're more short-term. So they're designed to really get at the issue, address the issue, give people skills that they can use to overcome those issues. Humanistic and client-centered therapies. You learned about Carl Rogers' approach in the personality theory chapter. The humanistic client-centered approach was really founded on Rogers' model, and his argument was always that the best expert on how you feel and why you feel that way is you. So basically, with client-centered therapy, you have a therapist who creates an environment that's characterized by unconditional positive regard. The therapist has to be genuine, has to be empathetic, has to create a safe space for that person to get insight into who they are and how they can grow. The whole sort of philosophy is, if you create a safe space for people, they will heal. Some argue this is naive, but for some people, it's genuinely the space that they need. If they've felt invalidated in their lives and they're stuck experiencing mild to moderate anxiety and depression, they may do better with a humanistic approach that really just gives them a safe space in which to work through some of the things that are challenging to them in the current moment. The therapeutic goal is to get the person back on the road to actualization. Therapists who purely practice a humanistic approach are not going to be directive. They're not going to tell people what to think, why they're thinking it. They're not going to tell them what to feel or how to feel it. It's the client that directs the course of therapy. So therapists, their job in this context, if they're using a purely humanistic approach, is to create conditions, create situations that allow the client to discover and make insights about their own feelings and realign their self-concept in a more actualization-oriented direction. The characteristics of the therapist are pretty critical in this approach. These are therapists who are trained to be highly accepting, genuine, and empathetic. And how they show that is by using a communication style that validates the person's own thoughts and feelings and ideas. It's not that they won't challenge things that their clients say that are hostile to self and so on, but they will largely provide a sounding board where the client shares how they feel. They'll be validated, their feelings will be validated, there will be further discussion, and the assumption is that by allowing people a safe environment for self-discovery, that they will start moving in the direction of growth that's healthy. So the supportive environment approach tends to be more successful with people who are not severely disordered. So people with mild to moderate issues who need a safe space to think about themselves, to talk through their issues. And it's the most successful for people who are really motivated to get more personal awareness and to push themselves to grow. This is not a therapeutic approach that's going to be useful for severely mentally ill people. Humanistic approaches, for instance, are not going to be particularly relevant for someone who is actively symptomatic with mania or schizophrenia, for example. Now, could somebody with those disorders benefit from humanistic client-centered therapy? Of course they could. If they're not in an acutely ill state, it may be extraordinarily helpful for them to work with a humanistic therapist to find that experience of self-love that is often missing. Behavioral therapies are typically very targeted. These are therapeutic approaches that involve both classical and operant conditioning, and they're designed to change specific, usually very well-bounded maladaptive behaviors and move them in the direction of adaptive behaviors. So, for example, if a person has a phobia of flying, and to be more successful in their job, they need to travel a lot. Well, the fix for that is to, engage in a behavioral therapy program that is designed to reduce or eliminate phobias of specific objects, like flying. So the assumption is that the behavioral symptoms are the problem, and that they can be, using operant and classical conditioning, they can be reversed. And you can replace the maladaptive symptom with the adaptive one. Maladaptive behaviors are assumed to be learned, and the further assumption is that you can replace them by unlearning the bad behaviors and replacing them with good ones. Behavioral therapies use a variety of techniques that you learned about in the learning chapter. One of these is a counter-conditioning technique. And in this case, what you're doing is you identify the maladaptive response and you replace it with an incompatible adaptive response. So let's say that a person has a phobia of flying on airplanes, and they tend to get a panic response when they think about planes or when they get on a plane, and so on. So early in therapy, what you might do is counter-condition a relaxation response to replace the response that revs up people into panic and encourages them to avoid those situations. So what people will be taught is how to do breathing, how to do imagery that is designed to be relaxing, and do that in the context of stopping the anxiety response kind of in its tracks. Counter-conditioning therapies have been shown to be really helpful for anxiety-related conditions. One type of counter-conditioning technique is called systematic desensitization. And Dr. Meyer, in his abnormal psychology class in the fall, they do some of these counter-conditioning approaches to teach people how to counter the experience of panic before it starts. So they learn relaxation techniques, breathing techniques, and then they do a systematic introduction to a phobic object. And in the case of his class, it's people with roller coaster fears. Dr. Meyer really loves roller coasters, and a surprising number of people are very fearful of roller coasters. So he uses that as a kind of experimental space for teaching people systematically to manage their fear of the fear object. So he starts them with just thinking about it, thinking about roller coasters, then looking at pictures of roller coasters, then watching video of other people riding roller coasters, doing VR of riding a roller coaster, all while practicing skills that are counter to fear. So practicing breathing, practicing imagery, practicing relaxation techniques that counter that fear response. I mentioned VR. Virtual reality therapies have been shown in relatively recent studies to be really helpful in the treatment of anxiety disorders, and in some cases in the treatment of PTSD, to give people a safe space where they can use their skills for combating the overwhelming emotional aspects of anxiety while they're in this safe space experiencing the things that tend to be triggering to them. Now, flooding is a more dramatic version of a counter-conditioning technique where you take the person who's terrified of something like airplanes and you just drag them onto an airplane, and they have to, through flooding, get over it. Now, some criticize that this is not the best approach. It can work, but many people find it very punitive and painful. And in some cases, it can backfire. Cognitive therapies, as the name implies, focus on your thinking. So in cognitive therapies, and there are a variety of types, you have therapists who are working to change the person's thinking from maladaptive patterns to adaptive patterns. In anxiety disorders, in depressive disorders, in OCD, disordered thinking, maladaptive, distorted thinking is very, very common. So in depression, for example, people tend to have very, very dark thoughts, thoughts that tell them that they are horrible, that they're helpless, that they're hopeless, that they're awful, they can't do anything right. All of these negative thought distortions tend to be associated with depressed mood, and they tend to make depressed mood worse. So in cognitive therapy, part of what's going on is that people are taught that their thought processes, what they believe to be true, are impacting their mood negatively, and what they have to learn is how to identify their irrational thoughts, call them out for what they are, and then change them, refute them. So, for example, in one tactic that cognitive behavioral therapists will use, so they'll have people who are very depressed, they'll give them a notebook and say, divide your page on your notebook in half. And on the left side of the page, write down every negative thought you have about yourself. On the right-hand side of the page, in therapy, they would work to refute each of the statements. So if the person says, I can't do anything right, in therapy, they would ask to identify at least one thing they did right that day. Even if it is, I put my shoes on. It's a practical, fact-based challenge of the thoughts. So what people are taught to do is to catch the thoughts on the fly, challenge them, and put them away. And over time, when people practice this, when they get good at it, they start to have fewer and fewer and fewer of the maladaptive thoughts, because they have trained themselves to identify and challenge them and dismiss them. Now, one older version of cognitive therapy is called rational emotive therapy. And this was an approach pioneered by Ellis. And it's a bit more brutal, to be honest, in the way it's done. The therapist is going to directly confront the client's unrealistic thoughts, and may do so in a fairly blunt way to show that the thoughts are irrational. Ellis proposed what he called an ABC model that many cognitive therapists, even if they don't adopt Ellis's tactics fully of being highly confrontational, the ABC model is pretty common in cognitive therapy. A refers to a triggering event, an activating event. B refers to the belief the person has about the event. Like I had a car accident not too long ago. It was minor, but it was annoying. So I had a car accident. That's the activating event. Belief, I'm a crap driver. I'm a horrible person and a crappy driver. C, emotional consequence. I feel awful, embarrassed, disgusting, blah, 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 blah. So ABC. And the client is going to be walked through what was the activating event, what was the belief, what's the emotional consequence, and then Ellis would then walk the client through. A doesn't cause C. B causes C. So it's not it's not the car crash that's depressing you. It's your belief about the car crash. So I have the car crash. I say to myself, I'm a crappy driver and a horrible person. The consequence is bad emotions. So for Ellis, he's going to challenge that person and say, it's not the car crash. Don't blame the car. Don't blame the crash. It's your own brain. It's your belief. Change your belief. So in his bluntness, that can often kind of shock people into seeing the overt absurdity of some of their negative beliefs, and it can turn some of them around. Now, in standard cognitive therapies, these are therapists who are trained in identifying dysfunctional thinking that is then believed to lead to disordered emotion and behavior. The assumption is you change the thought, you change the feeling. In Beck's cognitive therapy for depression, for example, unlike Ellis's rational emotive therapy, Beck found that it was really essential for the therapist to develop a warm relationship, a trusting relationship with the person, and then the person is taught through homework assignments to carefully consider whether or not their beliefs are true, and to identify this persistent errors in thinking, like overgeneralization and a variety of kinds of thought distortions. The therapy, when it is combined with behavior therapy, can be remarkably effective in changing people's emotions and in changing their behaviors. To wrap things up, you may be asking yourself, is psychotherapy really worth it? Generally speaking, the effect of psychotherapy as it relates to research, it's hard research to do. It's difficult research to do. Every therapist is a little bit different. Every client is a little bit different. Everybody's situation is unique. It can be very difficult to put people on a level playing field and try to evaluate this great big broad question, is it effective? Psychotherapy works when you have when you line up some caveats. If you have a solid therapist who has the tools that are the best fit for the symptoms and problems and concerns that you have, then the research shows that people do get more relief from psychotherapy than doing nothing. Spontaneous recovery is a thing, meaning over time, people with mild to moderate issues, psychological problems, do tend to get better by themselves. They, just the passage of time and interactions with friends and loved ones can allow people to feel better. What's known, though, is that when people, even if you're talking about mild to moderate problems and more severe problems, people get better faster when they're engaged in psychotherapy. So a meta-analysis that your authors describe, involving lots of different kinds of psychotherapy, when people go to get help, they tend to get better, and they tend to get better faster than if they did nothing. Now, as I said, it's difficult to do this kind of research from an ethical standpoint. You can't put people in a randomized controlled trial and test therapies when you're talking about emotional distress. It's not ethical to deny people the possibility of treatment when they are in emotional distress. So we have to look at this research in a different way because randomized controlled trials are tricky. What we do know is that the average psychotherapy client reports that they're better off most of the time than people who aren't receiving any therapy when you equate their level of severity of symptoms. We also know that no one type of therapy is better than others. So the final note there is, when we look at the research more holistically, and we look at the other kinds of treatment approaches available to us, right now, the research shows that the best types of approaches involve a careful consideration of what kind of psychotherapy is the best fit for the problem that the person is facing. So if the person is preoccupied with a lot of negative thoughts, a cognitive therapeutic approach is best. If a person has a specific behavior that they want to unlearn and replace, a behavioral approach is most effective. If a person has been traumatized and they want to work through that trauma, humanistic and psychodynamic approaches are probably the most effective. Thinking more broadly, especially when you're talking about moderate to severe symptomology, the best approaches tend to be mixed, where you have biomedical approaches mixed with psychotherapeutic approaches in terms of long-term outcomes. And that concludes my coverage of Chapter 10.